Welcome to the deep dive. Today we're really getting into the nuts and bolts of a comprehensive respiratory assessment.
Yeah, we want to give you kind of a quick but really solid grasp on the key steps clinicians use. How to rapidly check breathing and oxygen levels.
Exactly, sort of a well-informed shortcut.
Right. And the source material we're drawing from is very structured. Lots on techniques, tools, what's normal, what's definitely not normal.
So our goal is to pull out those critical signs, the things that scream, pay attention.
Precisely. The indicators that signal distress versus, healthy function.
Okay, let's maybe start with a super quick refresher. The main job is O2-CO2 exchange, right? And acid-base balance.
Yeah.
Yep. And structurally, don't forget, right lung's got 3 lobes, left has 2. Just a small thing, but it matters when you're listening. Okay. And the processes, there were 3.
3 key ones for gas exchange. First up is ventilation. That's just the mechanics. Air in, air out.
Simple enough.
Then diffusion. This is the big one. At the lung level, oxygen moving from those tiny air sacs, the alveoli, into the red blood cells. Problems here. That's hypoxemia, low oxygen in the blood itself.
Gotcha. And the third.
Perfusion. So the oxygen's in the blood cells. Now they got to travel and deliver it to the body tissues. If that fails, you get hypoxia tissues starving for oxygen.
Okay, ventilation, diffusion, perfusion, good baseline. So let's get practical. The initial survey, the toolkit, what do we absolutely need?
Well, the tools are pretty standard. Stethoscope, obviously, and remember, use that diaphragm firmly.
Right.
You need a watcher clock with a second hand, a pulse oximeter, a reliable one.
Right.
And often, especially post-op, an incentive spirometer nearby.
Okay, and the general survey, this is before we even touch the patient, right?
Yeah.
What are we clocking the second we walk in?
Instantly, you're looking at their position.
Yeah.
Are they relaxed or are they leaning forward, arms braced? That's the tripod position. Big warning sign.
We're sitting straight up, the orthopneic position.
Exactly. Both unexpected, both signal distress. Then level of consciousness. Are they alert, confused? Skin color, any cyanosis, that bluish tinge, or pallor, looking pale.
And just listening, even without the stethoscope yet.
Yeah. Can you hear abnormal sounds right away? Wheezing, gurgling. How hard do they look like they were working to breathe? Deep breaths, shallow.
Okay, so visual cues first. Then we need their story, the subjective part. What questions are non-negotiable?
Oh, definitely need history. Got a cough. Is it productive, bringing stuff up, or just dry?
Great.
Any history of infections, like PNA, pneumonia, bronchitis,
Yeah.
or chronic ceph asthma, COPD, chronic obstructive pulmonary disease.
And smoking exposures.
Absolutely. Smoking history is huge. But also ask about their job, environment, any dust, chemicals, fumes they might be breathing in.
And you mentioned a surprising one, the source is flagged.
Yeah, immunization status.
Yeah.
Asking about flea shots, pneumonia vaccines. It tells you something about their overall health awareness and prevention efforts. It's a good health promotion check-in.
That's a really good point. Okay, observations done, history taken. Let's get into the numbers, vitals, and rates.
You always need a full set of vitals, but for respiratory, we zoom in on the respiratory rate, the RR.
Expected range is 12 to 20 breaths per minute for an adult.
Correct.
And the technique, it's subtle, right? You don't want them knowing you're counting their breaths.
Ideally, yeah. Maybe rest your hand on their abdomen like you're checking their pulse while they're semi-reclined, Fowler's position. Count for 30 seconds. If it feels regular, then double it.
But if it's irregular?
Full minute. No shortcuts. You need the whole picture if the rhythm's off.
Okay. And when it is off, outside that 12-20 range?
Well, faster than 20. That's chypnea. Could be anxiety, fever, exercise, sure. But it could also be serious illness brewing, PNA, asthma exacerbation.
Yeah.
The body's trying to compensate.
And slower than 12? Bradycardia.
That's often more worrying, actually. Could be a neurological issue, head injury maybe, or commonly effects of opioids, sedative depressing the drive to breathe. Very concerning. Okay, rate covered. Now, the little gadget everyone knows, the pulse oximeter, SpO2. What's the target? Expected is high, 95 to 100%.
And the uh-oh number?
Less than 90%. That's generally considered an emergency. Needs immediate attention, intervention, letting senior staff know.
But you mentioned an exception, people with chronic lung problems.
Right, the COPD folks. Because they chronically trap air and have gas exchange issues, their baseline might naturally sit lower. Maybe 88 to the low 90s could be their normal. Doesn't mean it's good, but it might be expected for them.
So context matters. You can't just look at the number in isolation.
Never. And speaking of accuracy, the oximeter is super sensitive to interference. This is crucial.
Like what? What throws it off?
Oh, lots. Movement, obviously. If the patient's shivering or fidgeting, poor circulation is a big one. Hypothermia, cold fingers, peripheral edema, swelling. low blood pressure, hypotension.
And the sources specifically called out nail polish.
Yes. Dark nail polish blues, blacks, sometimes even deep reds can absorb the light the oximeter uses and give you a falsely low reading. Artificial nails, too.
So you actually have to take it off.
You really should, yeah. Or try a different spot, like an earlobe or the bridge of the nose if the fingers aren't working. Always correlate the reading with how the patient actually looks and feels. Don't just trust the machine blindly.
That's a super important clinical pearl. Okay, numbers check. Let's move to looking at the chest itself. Inspection, posture clues.
Right. Now we're looking at the thoracic cage shape. Symmetry is key. Normally, the depth from front to back, the anteroposterior or AP diameter, should be, quite a bit less than the width side to side, the transverse diameter.
About a third to a half less, roughly?
Yeah, something like that. The obvious unexpected finding is the barrel chest. That's when the AP diameter is almost equal to the transverse, like 1-to-1. The chest looks rounder.
Often seen in long-term air trapping, like emphysema.
Exactly. Also look for spinal issues, kyphosis, that hunchback curve, or scoliosis, a sideways curve. They can physically limit how much the lungs can expand.
Okay, shape noted. What about the effort of breathing patterns?
Well, watch closely. Are they using muscles in their neck or shoulders to help pull air in? Can you see the skin sucking in between their ribs, intercostal retractions? That's accessory muscle use. Means unexpected effort, they're working hard.
And those really distinct, unusual patterns, you mentioned Cheyne-Stokes.
Yeah, Cheyne-Stokes is quite specific. It's cycles. Breathing gets progressively deeper and faster, then shallower and slower, then stops altogether, apnea for a bit, then the cycle repeats.
Where do you typically see that?
Often in patients nearing end of life. Also seen with severe heart failure or raised intracranial pressure, ICP.
Okay. And the other one was Kussmaul's.
Kussmaul's breathing. This is deep, rapid, almost gasping breaths. Very labored. It's the body trying desperately to blow off acid.
And associated with things like?
Typically severe metabolic acidosis. So diabetic ketoacidosis, shock, sepsis, kidney failure. Very serious states.
Got it. Okay. Inspection done. Now we listen and maybe tap auscultation and percussion, the language of the lungs.
This is where the stethoscope really comes into play. Technique is everything here.
What are the key points for getting good sounds?
Have the client breathe through their mouth, a bit deeper than normal breathing. Crucially, listen side to side. Compare left to right at the same level as you move down.
And listen for a full breath cycle.
At least one full in and out breath in each spot. Don't rush it. And be really aware of sounds that aren't the lungs.
Like what? False alarms?
Oh, yeah. Your own breath hitting the stethoscope tubing can make noise. If the patient's shivering, that muscle tremor sounds like crackles sometimes. Even the paper gown rustling.
And the sources had that interesting one about chest hair.
Ah, yes. Very common mistake. Hair moving under the diaphragm sounds exactly like fine crackles or rails.
So how do you avoid misinterpreting that?
2 tricks. Either press down a bit more firmly with the diaphragm to sort of mat the hair down, or, the best way, just wet the hair slightly with a damp cloth. Stops the movement, stops the fake crackle sound, saves you chasing a non-existent problem.
Good tip. Okay, assuming we've cleared those hurdles, let's define the main abnormal or adventitious sounds. What are crackles or rails?
Think. Bubbly, crackly sounds. Can be fine, like cellophane crumpling or coarse, like Velcro ripping. It's usually air moving through fluid in the airways or sometimes collapsed airways popping open.
And they don't clear the cough?
Typically, no. That's a key differentiator sometimes.
Okay. Then wheezes.
Wheezes are musical. High-pitched, whistling, squeaking sounds. Think air being forced through narrowed tubes. Classic in asthma, bronchitis.
Right. And raunchy.
Raunchy are lower-pitched, coarser, like a rumbling or snoring sound, usually caused by thick secretions or mucus rattling around in the larger airways.
And these might clear with coughing.
Sometimes, yes. A good cough might shift the mucus and the raunchy lessen or disappear.
Yeah.
That's helpful diagnostically.
Yeah.
Okay. And the really alarming one, stridor. Stridor is serious. It's a high-pitched crowing or gasping sound, usually heard on inspiration. And the big difference, you often hear it without a stethoscope.
Just walking into the room.
Yeah. It signals that significant upper airway obstruction could be swelling, foreign object. It's a true medical emergency. Needs immediate action.
Got it. Whew. Okay, before we tie it all together, briefly, what about percussion? Tapping on the chest.
Percussion helps assess the density underneath. You tap with your fingers in a specific way between the ribs. Healthy, air-filled lung tissue gives off resonance, a low-pitched, hollow sound.
And abnormal sounds.
If you hear hyperresonance, it's a louder, lower-pitched booming sound. It suggests too much air, like an emphysema or maybe a pneumothorax.
And the opposite?
Dullness. That's a soft, muffled, thud-like sound. It means the airspace is replaced by something denser fluid like a pneumonia, or a solid mass like a tumor. Okay, resonance is good, hyperresonance is too much air, dullness is density. Makes sense. So section 5, pulling it all together, applying this knowledge. Let's talk hypoxemia, low blood oxygen again. Early versus late signs. Why is catching it early so vital? Because the early signs are subtle, often behavioral. The body's trying hard to compensate. You'll see things like restlessness, maybe some anxiety they didn't have before.
Things you might easily dismiss.
Exactly. Also, faster breathing, tachypnea, faster heart rate, tachycardia, maybe slightly higher blood pressure, looking a bit pale. If you see someone suddenly get anxious or restless in a hospital bed, think oxygen first.
And if we miss those, or things worsen, we hit the late stage.
Yeah, and the late signs mean the body's failing. The heart rate slows down bradycardia. Extreme restlessness might flip to lethargy or even stupor. You can see abnormal heart rhythms, dysrhythmias. Blood pressure drops. And then you see the obvious cyanosis, the blue tinge. Going from anxious to stuporous is a really bad sign.
A critical shift. Now, our sources also highlighted that assessment needs tweaking for older adults. What changes?
Well, aging naturally affects the lungs. They tend to have decreased expansion, fewer functioning alveoli. Their cough reflex often isn't as strong. Lungs lose some of that elasticity, the recoil.
Which means
Higher risk for shortness of breath generally. And critically, a higher risk for PNA pneumonia because clearing secretions and fighting off bugs gets harder.
And that impacts how we do the assessment.
Definitely. They can tire out easily during auscultation, all that deep breathing.
Yeah.
You need to pace it, allow for rests. Also, they often have a decreased sense of thirst, get dehydrated easier.
Leading to thicker mucus.
Exactly, which just compounds the risk of congestion and infection. So encouraging fluids is extra important.
Okay, so shifting to prevention health promotion. What key interventions came up?
2 big ones. First, really thorough tobacco cessation counseling. Not just stop smoking, but explaining the risks clearly. Heart disease, stroke, cancer, and including the dangers of secondhand smoke too.
Crucial. And the second?
Immunizations. Pushing for the annual flu vaccine and making sure anyone over 65 or younger folks with chronic lung issues like COPD get their pneumonia vaccine. Prevention is always better than treatment.
Absolutely. So wrapping up, we've covered a lot. From spotting distress positions like the tripod to checking that pulse ox carefully, avoiding things like nail polish interference.
Yeah, and learning to differentiate those key sounds, the wheeze of narrowed airways versus the emergency crowing of stridor. It's about putting all those pieces together.
And this assessment isn't just data collection, it directly leads to actions, especially for those high-risk patients like post-op.
Absolutely. For them, it's about being proactive based on this assessment knowledge, encouraging that incentive spirometers use like 10 times every hour they're awake, pushing deep breathing and coughing.
Positioning frequently.
Yep, at least every 2 hours to prevent fluid pooling. And keeping those fluids up, aiming for 2-3 liters a day if possible to keep secretions thin. It's all aimed at preventing nasty complications like atelectasis, collapsed lung tissue, and pneumonia. This isn't just theory. It's practical, priority care.
Okay, so here's a final thought to leave you with, building on that idea of subtle signs. We talked about how early hypoxemia can just look like restlessness or anxiety. Knowing that now, how might that change how you observe those basic behavioral cues, maybe even in yourself or people you know? Realizing that a simple shift in alertness or mood could actually be masking a significant physiological problem like dropping oxygen levels makes you think differently about just feeling off, doesn't it?